Good evening, everyone, and welcome to our prostate cancer update. My name is Helene Gilmore, and I'm the Workforce Development Officer at Western Victoria PHN. I'll be a facilitator for this evening, and alongside me is Jade, who also in the Workforce Development team. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respect to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations. And I'm dialing in from Wadawurrung country tonight. Just a little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel. We will put this link to access our recorded webinar events into the chat. And also, please see our upcoming events on the screen now. You can register for these events on our website, and the links on there will be in the chat as well. We'd like to highlight a few key face-to-face networking events happening across Western Victoria during March. If you could take advantage of an opportunity to network with your peers and enjoy a complimentary meal at either a GP dinner or practice manager, practice nurse breakfast in your region. Registrations are now open on our website. Please make note of our West Vic PHN Health Pathways that's relating to the topic, and that's on your screen at the moment. If you have entered the webinar not displaying your accurate first and last name, could you type your full name into the chat box? Only the admin will see this, and this is to ensure that you get your certificate of attendance. For this evening's webinar, all participants will remain on mute, and if you have any questions, please type them in the question and answer box, and I will ask them on your behalf to the presenters during question and answer time. There is a link in the chat box to complete the survey after the webinar, and we'll show this again at the end. Our presenters for this evening are Mr. Adee Davidson, Urologist, and starting off the webinar this evening will be Bridget Hill, who is a Prostate Cancer Specialist Nurse. So I'll hand straight over to you, Bridget, and we'll get started. Thank you.
Hi there, my name is Bridget and I'm a Prostate Cancer Specialist Nurse for the Southwest region of Victoria. I'm based at the Southwest Regional Cancer Centre in Warrnambool. I'm one of over 100 nurses Australia-wide. My role is funded by the government and supported by the Prostate Cancer Foundation of Australia. The PCSN service is a free for all men and their families, and I work alongside medical specialists, allied health and metropolitan services where patients may receive treatment. The PCFA have set out a practice and capability framework to help define the purpose of the PCSN role within our healthcare settings. This includes prompting quality survivorship care, which is a large part of my role. As specialist nurses, we have expertise in and in-depth knowledge in the physical, psychological, and social effects of prostate cancer. Our care includes not only men with prostate cancer, but also their partners, family members, and loved ones. We provide an expert point of contact, as well as streamlining service delivery when a referral to another centre is required. We use evidence-based practice to better educate and care for patients to meet supportive care needs and maximise quality of life. Our role informs and influences practice at an advanced level through quality improvement initiatives by acting as valuable resources for other healthcare providers. I provide an ongoing point of contact and support locally, assisting with accessing services in the treatment facilities and community during and after treatment, care coordination between different healthcare facilities, referrals to healthcare providers, physios, specifically those trained in men's pelvic floor health, counselling, dietitians, continence, men's health nurse practitioners, amongst others. Helping to access support groups, education and information relevant to the individual situation, community engagement and awareness, and communication and developing rapport with the treating teams. It has been demonstrated that about 50% of men have unmet supportive care needs, particularly around sexual function, psychological issues, fear of cancer recurrence, and worry about the future. Astonishingly, men with prostate cancer are 70% higher risk of suicide than men in the general population. This risk is higher in men who have had a higher stage disease, live in the cities, and are unpartnered or unmarried. A large part of my role includes advocating for the patient's mental and physical health. I will often encourage improvements in physical health for men on hormone therapy by linking them in with free online or face-to-face programs locally, run by exercise physiologists that are supported by some of the pharmaceutical companies, and encouraging peer contact through men's group fitness programs or via the local support group. I'm able to see patients at any time throughout their cancer trajectory, even if they have had treatment years ago but may be still suffering from the side effects of treatment. I have found that being present at the very beginning of a man's diagnosis allows us to develop a rapport, and the patient then feels more comfortable to reach out should they have questions or concerns or are requiring care coordination, especially in the early days where they may be waiting further tests, such as a PSMA PET scan, waiting for appointments to discuss results, deciding on treatment pathways that best suit them, and awaiting on treatment to occur. The positive feedback that I get from these men and their partners verifies their relief and gratitude to have a key contact person available at times where their levels of distress and anxiety are high and their lives upturned following a cancer diagnosis. Following a diagnosis, I will sit down with these men, give them an information pack, and help them determine their next steps and listen to their concerns. I will always follow up with a phone call after they have had time to absorb their diagnosis and what life might look like moving forward. Nearly 3/4 of men with prostate cancer will not seek help for their distress. Having frequent contact with men who may not otherwise reach out to or seek help is vital. They often have a high fear of cancer recurrence, lower life satisfaction, and impaired quality of life, often stemming from treatment side effects such as a loss of continence or sexual function, or a threat to their relationships, intimacy, sense of masculinity, and a loss of sense of self. I will express that the Prostate Cancer Specialist Nursing Service is complementary to all healthcare providers involved in the care of these men. My aim is to support these men and their families, spend time with them, educating, listening, and helping them in all aspects of their survivorship care. I have placed my contact details onto this slide, and they can also be accessed through the Westvic PHN website or the BizRix websites. If you can see the poster here on the screen, this is one of 4 posters that you may see around your clinics or throughout the general community in all of Southwest Victoria, including the Geelong area. The Geelong and Warrnambool prostate cancer support groups were accepted for funding by the PCFA last year to come up with an awareness campaign. The reason for this is that it has been found that men in our area are being diagnosed at a later stage of prostate cancer compared to the general Australian population. The consequences include a 50 to 60% higher mortality rate. The support groups teamed up with BizRix, who also contributed to funding and collaboration to come up with a media campaign. We launched earlier this year and have been advertising heavily on social media, as well as local government areas, councils, sporting groups, businesses throughout the Geelong, Warrnambool, Hamilton, Portland, Colac and surrounding areas. The aim is to create awareness and to get people to know their risks, check their family history and speak with their GP about getting tested. If you want to know more about this local campaign or would like some hard copies of posters dropped into your clinic, please reach out and we'll be more than happy to facilitate this as well. And that is it from me. Thank you very much.
My name's Adee. Thank you for giving me the opportunity to have a chat. So we were going to talk about basically prostate cancer, the ins and outs. Look, some of this stuff may be known to people, but probably worthwhile just rehashing stuff. It's always good to revise. So start off with the basics. What's the prostate? Small gland located at the base of the bladder in front of the rectum, obviously only in men. It's part of the male reproductive system, and the main reason for it is to produce seminal fluid, which is obviously important for fertility. So it assists in the basically the delivery of sperm for conception. The prostate, and obviously treatment of prostate, the main risks relate to where it is and the structures around. So as you know, it sits at the base of the bladder in front of the rectum. As us blokes get older, the prostate grows. It's a natural part of aging. And because the urethra runs through the middle, it can be squeezed and result in lower urinary tract symptoms. But what we're talking about here is not benign growth. We're going to be talking about prostate cancer. So look, just some of the basic stats. Apart from skin cancers, it's actually the most common cancer diagnosed in men. Depending on the statistics, and these are all sort of Australia-related statistics, about 19,000 men are diagnosed each year. The risk of cancer increases with age. Overall, the lifetime risk of being diagnosed with prostate cancer is about 18–20%. But most importantly, the risk of actually dying from prostate cancer is low, so 2%. So that's where the whole saying, people die with prostate cancer rather than from cancer comes from. And obviously, for the most part, that is true. But the most important thing to remember is that depends on the patient's age at diagnosis, and also the degree of cancer or the grade of cancer that they have at diagnosis as well. In terms of natural history, sort of just reiterating what I said, it's very, very common, but it's not the leading cause of death, of cancer death. Most men diagnosed don't ultimately die of their disease. Whilst there may be effective therapies for treatment, most people don't die from their disease, and obviously for some of the population that is because of the effective therapies that we have. But the main reason being that a lot of the prostate cancers end up being indolent or dormant. And for that reason, sometimes we do actually end up overlooking the potential seriousness of the disease. So in other words, with the blanket statements about prostate cancer, we end up throwing the baby out with the bath water. And certainly in my practice, I do get younger patients who come in saying, oh, this prostate cancer thing, we don't really need to do testing, and people die with it, not from it. And these are the young guys who actually are the ones who benefit the most from detection, early detection, and then effective treatment. I guess the other important thing to say is these general statistical statements, they're not personalized. And a lot of medicine really is delivered for the greater good, and obviously that's important. The last thing we want to do is start over-detecting, over-treating, because as I say to my patients as well, over-treatment is just as bad as under-treating the odd patient as well. But it is important to note that early detection and appropriate treatment does improve prostate cancer survival. And that graph basically just shows over time how that is certainly what we see in the data. And that would be related to PSA, the development of PSA, and then, further along, our understanding of how to interpret PSA. And then more effective biopsy techniques, the use of MRI, and even understanding of active surveillance and other treatment options. And you can just see over time, we've had a gradual improvement in overall prostate cancer survival. So how do we diagnose prostate cancer? So it's a combination of things. Obviously, usually it starts with the GP and a blood test. A lot of times that can be instigated by the patient or the GP. We then what I would do is, depending on sort of my assessment, I would usually organise an MRI. That's now funded by Medicare, and then we would follow that up with a prostate biopsy. And obviously, also in some In some older patients, we may not go through the process of an MRI or a biopsy. It can be done basically as a clinical diagnosis based off the PSA or the digital rectal examination. But for the most part, it would be PSA blood test with an MRI plus or minus a biopsy if indicated. So what's the deal with PSA testing? So the PSA is a protein which is produced only by the prostate and can be detected in the blood. That's why it's a useful test. The important thing to remember, though, is that the PSA level, it's organ specific. It's not disease specific. So it can be associated with many conditions of the prostate. And really the only one that we're concerned about is cancer. So, and what I usually say to my patients is I say the PSA level is a risk tool. The higher the PSA, the higher your risk, but it's never 100%. The lower your PSA, the lower your risk, and it's never zero. So even when we say to patients, your PSA is normal, we're not saying that you don't have cancer. We're basically just saying your risk at this moment in time doesn't warrant further investigation, but it is important to remember that you do need to continue to keep an eye on that PSA because their risk profile would change with age. So it is important, even just to allay patient concern, if the PSA is high, it doesn't automatically mean they have cancer. And a lot of patients worry about that. So organ specific, not disease specific. Obviously, there are limitations because of this. But at the end of the day, it still remains the best or the simplest test to assess a man's risk of prostate cancer. And the testing of the PSA has reduced prostate cancer morbidity and mortality. So that all just covers what I said. So there's a couple of things that's happened in the last couple of years. I think this chart is important to remember, but with MRI funding, it's kind of moved this chart around a little bit in the way clinicians view PSA, and I'll explain that statement in a sec. But basically, because we know the PSA gradually goes up with age, relative to the risk with age, the thresholds change. And so you can see there, 40 to 49, PSA under 2.5, 50 to 59, PSA under 3.5, 60 to 69, under 4.5, and then greater than 76.5. And this really just reflects the natural sort of elevation in PSA with prostatic enlargement and age. So again, there's sort of stratified ranges. I would always do a digital rectal examination. GPs, I think, depending on their level of familiarity, will or won't. I don't know. I don't necessarily know that it's the sort of absolute thing that needs to be done. Very rarely, not infrequently, I'll get referred patients who have had a DRE, maybe at the time of a colonoscopy, with a clear malignant nodule and a PSA that's normal. I think as a screening tool by itself, it's probably not that valuable. The pickup rate would be quite low by itself. What the society sort of state in relation to PSA screening, although it's not screening in the sense of breast cancer screening or fecal occult blood screening, it's more of a sort of nuanced discussion with the patient about the pros and cons. But really what we feel as a society is most men should be tested between the ages of 50 to 69. Above that sort of 70 to 80 is more than reasonable. We really want the patient to have a 7 to 10 year life expectancy. The group that's really difficult is that sort of 79 plus 80-year-old. They're a very hard group to know whether they're actually looking for cancer and then actively treating them will benefit them, because unless the patient has a sort of 7 to 10 year life expectancy, active treatment, difficult to know whether we're actually making a survival benefit for those patients. I think the important message here is if the patients have a strong family history, they probably also should be encouraged to have testing, and certainly at an earlier age as well. So one of the ways that we as urologists would direct guidance, if you've got a patient who's sort of 40s, who has a father who was diagnosed at a young age, like say, in their 50s or 60s, ended up needing treatment. Certainly if they were diagnosed with an aggressive cancer at a young age, they probably should start their PSA monitoring at 40. What we'd say is you sort of look at that baseline number. Now, if that baseline number is exceptionally low, like below the median range, then you probably can just sort of do another one at 45. And if it continues to be very, very low, you could probably just do yearly after 50 or yearly after 45. It just depends. If you did a baseline at 40 and their PSA, although normal, say is in the high normal range, you probably should be doing yearly PSA on that patient at an earlier age, because that would sort of suggest, although the PSA is within the normal range, it's high normal. So again, it would suggest that their risk is a bit higher. You really want to see that level below the median. That's sort of our guidelines. So that's that. So the final take-home message from PSA is obviously to remember it's not an infallible test. However, it still remains the best test at detecting early localized prostate cancer. The most important thing is we do need to ensure that we know, we need to ensure that we don't overtreat insignificant cancers and we don't miss significant ones. And in a way, that's where the PSA comes in, because that's really the first port of call. When I was talking about the MRI, I actually have a feeling, no. What's happened now is the Medicare rebate or the guidelines for ordering an MRI have basically shifted the PSA ranges down pretty much for everyone, essentially, if they've got a PSA under 3.5. So it's kind of ended up being that, at times I'll end up doing MRIs when the PSA sometimes is within normal range, but not always. And so still sort of look at the overall trend, the examination. The other thing that I didn't put in the slide, which is a useful test, there's also a free to total ratio, which can be done on a PSA. You do need to specifically ask for it. It is important because it is one of the parameters that's used to get a Medicare funded MRI. Effectively, it works the opposite way. So the lower the free to total ratio, the higher the overall risk of cancer. But again, the free to total ratio is only useful if the PSA is between the level of 4 and 10. So if the PSA is under 4 or greater than 10, the free to total ratio is not that important. And the other thing to say, which is very, very important, we shouldn't really do anything based off one single PSA. We really should repeat an elevated PSA about 4 to 6 weeks later. We should make sure that there's no obvious urinary tract infection. We should also remind the patient to ensure that they don't ejaculate within 3 days prior to the blood test, because that will artificially raise the PSA. And certainly in my practice, I've had many patients who were referred with a single PSA, and we will repeat it, and the repeat is literally back to baseline, and there's no real need for them to see a urologist. So it's important to remember that. So in relation to the MRI, this has been a massive change in the management, in the diagnosis of prostate cancer. When I started off my training, these didn't exist. We literally assessed a patient based purely off the PSA and then biopsied everyone again and again and again. Now with the MRI, effectively what it is, it's an imaging tool that will give us a risk assessment. And you end up getting a number. It's a PIRAD score. It's a similar sort of thing to what happens with breast cancer imaging and risk assessment based off that. But effectively, a normal scan is what we would call a PIRADS 2. And again, we're not saying they don't have cancer, but we're saying that the risk of a significant cancer is low. And I would not routinely biopsy this type of patient. I would keep an eye on them and just see how things go. It is pretty uncommon to end up having a high-grade cancer in this type of scenario, but it's not 0% risk. So it's not, again, it's not just a scan that we do and then sort of say, see you later, don't worry. We do need to continue to keep an eye on things. A PIRADS 3 lesion is an indeterminate lesion. So again, the definition is basically clinically significant cancer is equivocal. And then obviously if there's a PIRADS 4 or a PIRADS 5 lesion, that's a sort of significant lesion that we absolutely would biopsy. HIRAD3 lesions, again, depending on patient factors, age, etc., how big the lesion was, we may or may not biopsy that. So basically what MRI has done, it's actually eliminated unnecessary biopsying, helps us decide. More importantly, it's actually also allowed us to better target areas of suspicion. In the old days, it was literally just a template, a sort of random biopsy in several zones. So you could absolutely miss cancers that way. What the MRI has done is it has allowed us to target specific areas and know that we're effectively going where the money is when we do a biopsy. It's nice, even if we have a low-grade cancer on diagnosis, it's nice to be able to then also show that the MRI showed no suspicious lesions. So again, it can just help confirm active surveillance in patients who have low-grade cancer who don't really require active treatment. It also has helped in how we treat patients, surgical planning, and also radiotherapy planning if we're concerned about, wide. So we're worried about sort of capsular involvement with prostate surgery. We know to go wider on that side when we're operating, so it helps in that respect too. So that's MRI. Fortunately, the base hospital, Loomis, have a T3 MRI machine. And so that's the most reliable MRI to be done. Traditional 1.5T machines, which is probably more in number in the community, are not as reliable. And again, obviously we can do them, but they're just not as reliable. But for the community, we've got what we need, so that's fine. So biopsy, again, this is something that's changed. When I started my career, we only did transrectal ultrasound guided biopsies. There was obviously a risk of infection because the needles was placed through the rectum into the prostate. We also were limited to the number of biopsies we could do because every time we pass the needle through the rectum, your theoretical risk of infection goes up. So typically we tended to do 12 to 16 maximum. So you could imagine that, depending on the size of the prostate, there's large areas of the prostate that you would miss when we did that biopsy. And then obviously we were also worried about infection. The anterior zone of the prostate, which is this part here, coming from below, was also a difficult part of the prostate to access. And up to 20% of prostate cancers can reside in this area. And so they tended to get missed with truss. The other thing, MRIs have helped us in this anterior zone as well. So if we've got an anterior lesion on an MRI, we know that we need to get to that spot. So now a majority of biopsies have moved to what we call a transperineal route, and that's what this picture here is trying to show you. So again, we still need an ultrasound probe in the backside so we can visualize the prostate. But instead of passing the needles that way, we now pass the needles through the perineum directly into the prostate. The risk of infection is almost zero. Nothing in medicine, zero, and you can still get a skin infection, but it's effectively zero. We can also pass the needle many, many more times. We can also target and hit the anterior part of the prostate much more easily. And so it's made a massive difference to how we diagnose prostate cancer with less morbidity. I always say to my patients, we stick the needle from here and it goes in there and it actually sounds horrendous. It's actually a very well-tolerated procedure. It still requires it requires a general anesthetic, whereas previously the truss could be done under local, but usually just with a little bit of sedation. It is a procedure that takes a little bit more time to perform. The main risks are still the same, sort of blood in the urine, blood in the ejaculate. They do get a bit of bruising in the perineum down below. I've done maybe 700 of these. I've only had one infection and I've had 4 patients that couldn't pee properly. They had some retention following the procedure. Apart from that, literally just a bit of bruising and some bleeding. Very, very well tolerated. So that's sort of the whole diagnosis and then sort of biopsy, MRI, that sort of aspect of it. We'll move a little bit into sort of treatment. This talk was more in relation to localized prostate cancer. We can talk more about other stuff, that's fine. But In relation to localized prostate cancer, really what we're talking about treatment with the intention of cure. So therefore treatment with the intention of prolonging a man's life, and also treatment with the intention of trying to eliminate the need for sort of further other treatments down the line, like hormone therapy, etc. If we sort of needing to utilize hormone therapy as a treatment option, that's more of a sort of longer term management rather than a curative treatment. But we basically break it down into risk groups. Obviously, we take into account patient preferences for treatment, and we also think about patient factors. Again, broad risk group stratification is going to depend on the ultimate histology of disease, as well as the PSA and some of the information we get from imaging tests. And it obviously makes perfect sense that the lower the grade of disease and the earlier we pick it up, the better outcomes that patients are going to have. The Gleason grade score is something that's been around for years and years and years. It's probably what most people know. But in the last sort of 10 years or so, there has been a new grade grouping developed. It's called an ISUP grade, and you can see that there in the table here. Look, it's very, very similar to the Gleason score, and really the main reason why it was developed was more in relation to separating the traditional Gleason 7s out. Now, if you guys can recall, the Gleason score is basically where the pathologist looks at the specimen and assesses the nuclear atypia of the glands, and they'll give it a number. And basically the number, don't worry about 1 and 2. It's never given. That's normal. So really cancer starts at 3, 4, and 5. And so best way to think of it, 3 is sort of not aggressive, mildly aggressive, and significantly aggressive. And what the pathologist does is they just basically look at the volume of disease of the two most common patterns. So if the biopsy only shows pattern 3 with nothing else, that's called 3 + 3, 6. If it shows majority 3 with a little bit of 4, that's 7. And if it's majority 4 and a little bit of 3, in the old Gleason score, that was still 7 as well. But we know that Gleason pattern 4 is very, very different to Gleason pattern 3. And indeed, what we actually think is pure pattern 3 disease, that's the stuff that doesn't spread. That's the indolent, low, slow-growing disease that majority of men die with, not from, because we don't believe the pattern 3 truly has the ability to spread and metastasize and cause sort of cancer mortality. It's pattern 4 and pattern 5 that does that. So it makes sense that the more pattern 4 seen on the specimen, the more chance there is of it affecting your overall outcome. And that's certainly what we've seen once we broke it down into the ISUP grade group. And you can see there's a very big difference between having grade group 2 and grade group 3. And then again, it's almost like the pattern 4 here is what really starts impacting on overall survival after treatment. So that's the main reason why the ISUP grade group sort of came into effect. It was more to separate out that. This is a basic sort of overall risk stratifier. So again, this sort of here is the sort of local staging. It relates to sort of volume of disease on the left side, on the right side, on both sides, growing to the capsule, to the seminal vesicle. So obviously, the more advanced locally the cancer is, the higher the risk goes up. Same with the actual grade group. So you can see pretty much 6s here. Always puts you in a very low and low risk. You really need to get 7 before you can even start getting into an intermediate risk group. Obviously, the higher the PSA, same deal. And it all makes sense here. As you go up the grade score and your PSA goes up, your overall risk becomes higher and higher. Active surveillance is what has come out over the last sort of 20 years from the data that was originally sort of picked up, which has now matured to about 15 years, where we've now realized operating on Gleason 6 prostate cancer was an absolute waste of time. And indeed, when you look at the two arms, actually the people who ended up getting treatment have done worse than the ones who we left it alone. So now what we say is, we're not treating you, we're going to watch you. Obviously, we still need to watch, because at the end of the day, we're always worried. You know, to the best of our knowledge, we assume that there's only Gleason 6 disease in there, but we could always be missing something. And so it's important just to make sure we're not missing a higher grade disease. We do not think that Gleason 3 over time becomes 4, over time becomes 5. That's not really how we think the biology of the disease works. So active surveillance is not necessarily so much looking, you know, making sure that the patient doesn't transform. It's just making sure that we've picked the right patient for active surveillance. And the ideal patient is the pure Gleason 6s, the small volume of disease, the PSA under 10. We love to have a normal MRI. And you can see that the overall risk of progression and sort of, you know, mortality over time in the ideal patient actually very, very low. And so that's why. But active surveillance does involve regular follow-ups, you know, PSAs, repeat MRIs, repeat biopsies. But, you know, in my practice, I'm really looking at trying to, you know, for me, every patient is active surveillance unless there's a clear indication that we need to, that it's inappropriate. I'll absolutely accept a little bit small volume pattern 4, particularly in older patients, particularly if the MRI is reassuring. So again, there's no hard and fast rules here. There are the ideal patients where we know what the risk of effectively what I tell my patients, missing the boat. But then in older patients, it may be reasonable to accept a slightly higher risk, given that at the end of the day, sort of missing the boat in that older cohort, it's not necessarily the end of the world, but in younger patients, it's a bit of a different story. So again, there are rules, but sorry, not rules. There are suggestions, there are protocols, but it can be interpreted, particularly with the patient, and everything is a risk discussion. If if the patient's got definitely intermediate or high risk disease, then we usually talking about active treatment. Look, there's always two options. There's surgery and there's radiotherapy. If you just do a head-to-head between the two, look, cancer outcomes are the same. I can't sit here and tell patients, you know, you need surgery because surgery is better from a prostate cancer perspective. Radiation is just as effective, but they are two very different ways to treat the cancer. Just touching on a couple of other treatment options, non-localized or treatment in the elderly. I use a lot of watchful wait in patients who I really don't think has a, you know, greater than 5 to 7 to 10 year life expectancy. And in that respect, really what I'm saying is, look, you know, active treatment to cure you is not going to make you live longer. We'll just watch the PSA. In the future, if things change, then maybe we'll slow things down with some hormone treatment. But most of the time, it never really gets to that, and the patients will pass away from something else. Having said that as well, starting hormone therapy will just suppress the PSA, and that can go on for many years as well. Obviously, there are negatives to hormone therapy. It does have effect on the heart and bone health, sugar control. Patients do suffer from hot flushes. They can put on a bit of weight and get moody. But at the same time, radiotherapy and surgery and all those type of things in patients are not without risk as well. So watchful wait is a very, very good option in the appropriate patient. Obviously, if we're dealing with initial presentation with metastatic disease, in that scenario, achieving a cure is almost impossible. Usually the treatment in that scenario will still depend on patient age. It will usually end up being a multimodal treatment. It may involve surgery and radiotherapy and hormones and more recently novel agents and other things that are coming out in chemotherapy. So this would usually be approached in a multidisciplinary type manner. We certainly have very, very effective treatments and new ones coming on all the time that will absolutely extend the patient's life expectancy and quality of life. Just touching on surgery, the big sort of change that's happened in the last 15 years is robotic surgery, massive difference. Most public hospitals now are getting robots. Open operation is almost almost finished. There's just a couple of big hospitals left in Melbourne that don't have a robot, so they're still doing open operations, but effectively robotic surgery has taken over. It's keyhole surgery. Most patients are in hospital 2 days. The benefits are less blood loss, return to work quicker. The two main issues with surgery, as I'm sure everyone knows, relate to continence and impotence. Incontinence with robotic surgery, the overall data says 3%. In my experience, it's lower than that. Yes, every man will have some incontinence immediately after surgery when the catheter is removed, but the majority of men by about 12 weeks are relatively dry. When we're talking about that 3% incontinence, really what we're talking about is the just terrible multiple pull-up pads a day, barely going to the toilet because the bladder's empty all the time. We're not really talking about the stoic farmer who's, pulling stumps out and dribbles a little bit because he's been straining so hard. That's not really the stuff we're talking about. Every bloke will potentially get that from time to time, particularly when it's late in the day and they're tired. But these patients don't even necessarily wear a panty liner. It's so insignificant. But anyway, there is that risk. And so that is important. Rectal injury. So obviously because of the location of the prostate, look, you can put a hole in the rectum. You can end up with a temporary colostomy. It's very, very uncommon. 1%, in my experience, is less than that. Impotence is the other big one. And the most important thing to remember with impotence is, look, it really does depend on the pre-op erectile function. If the patient doesn't have great erections to start off with, then they're certainly not going to be better afterwards. And it is important for patients to know that. But the whole deal with impotence relates to the nerves for erections, which run on either side of the prostate. Now, with robotic surgery, where our vision is much better than the open operation, we can actually get into the plane and leave the nerves behind. I always say to my patients that the nerves are like Glad wrap on a potato that you put in the microwave. It literally sort of sticks down, and you need to get into that plane and brush it aside. In some patients, we do not want to do that. So like I was saying before with the MRI, if we've got someone with high-grade disease, particularly high volume, particularly to the margin of the prostate, and we worry that it may actually already be invading the nerves, well, we're not going to try and save nerves in that patient. We would counsel the patient that unfortunately the degree of cancer requires a large margin operation. And at the end of the day, the operation is a cancer operation first. Having said all of that, robotic surgery has improved erectile function rates significantly. Generally, what we say is if we are able to save both nerves, then your return of erectile function's about 70%. It takes time. It takes a sort of rehabilitation program, but generally 70% of men with good preoperative erections and a bilateral nerve spare will get their erections back. They may need to have some Viagra or PED5 inhibitors, but it'll be sufficient for penetrative intercourse. If we're only able to save one nerve, we say about 50-50. If we're unable to save any nerves, the data says 30%. In my experience, that's way too high. It's much lower than that. It's a bigger deal. So if we already know that we're doing a bilateral wide excision, from my perspective, better to counsel the patient that erectile dysfunction will be an issue. Having said all of that, intracavernosal injections do not depend on the nerves. So we've still got medications to achieve erections post-procedure, even in that scenario. Vacuum pump devices work. I always say to my patients, sort of, once we're over the cancer diagnosis and you're in that sort of area where the PSA is undetectable and everything's great, and you sort of reflect back on all the things you've lost, as long as the patients and their partners, because it's a team effort, are open to the things that we have available to get an erection, and I think Bridget will attest to that as well. We can really work on those things once the dust has settled on the other side. But certainly the main issue that men worry about in relation to active treatment or surgery does relate to incontinence and erectile dysfunction. So in terms of just overall outcome, look, for the majority of men, prostate cancer is treatable and curable and does not recur, but it obviously depends on those things we spoke about before. It's going to depend on the prostate cancer stage and grade of disease. Like I said before, the overall treatment outcomes across the modalities are similar. Two cohorts. I wasn't going to talk too much about radiotherapy. It's not really my area. I generally say to patients in relation to outcomes, radiotherapy is the same, just obviously a very different treatment course. In terms of just the nitty and gritty of radiotherapy, there's a couple of different protocols. The delivery of the overall dose is still the same. It's just whether you want to give them higher doses over a shorter period or smaller doses over a longer period. So here in Warrnambool, it's basically either a 4-week treatment, 5 days a week, about half an hour each day, or 7 weeks, same deal, 5 days a week, about half an hour each day. It may be combined with hormones. So that's another difference. We do not use hormones in surgery. But radiotherapy, there are benefits in combining hormones with radiotherapy. That would be a short course of hormones, but it does add that level of potential side effect from the actual hormones. And again, there's different protocols. It can be 6 months, it can be 12 months, it can be 18 months. There's all different protocols. What patients usually complain about with radiotherapy is fatigue towards the end of treatment, obviously because the bladder and the bowel are in the vicinity of the prostate. Although they're not targeted with radiation, they do end up getting a bit of scatter. So you can end up with some bowel dysfunction, some bladder dysfunction. And again, look, longer term, the risks of radiotherapy, they're not too dissimilar to surgery. And what I mean by that is you can end up burning a hole in the rectum and end up needing a diversion surgery because of a rectal hole. It's very, very rare, but it can happen. Similarly, with the bladder, you can end up having issues with blood in the urine and bladder dysfunction from the radiation. And every now and again, we end up needing to divert a patient's urine because of the effects of the radiotherapy. Again, though, very, very rare. Over time, the radiotherapy will affect the nerves. So you will end up with erectile dysfunction over time. And similarly with continence, the radiotherapy will affect the sphincter. You can end up getting scar tissue in the urethra. And so you can end up with incontinence. So really what I say to my patients is it's kind of the same, but with surgery, your risks are immediate and then they improve. With radiation, you don't really get them at the start, but over time, these things can become a factor. And so one of the things I think I think that in the patient's mind, a lot of times the treatment, surgery or radiotherapy, it kind of self-selects. And what I mean by that is younger patients who are fitter and healthier and the overall risk of surgery is lower tend to have surgery. And older patients with a couple of medical comorbidities where the immediate risks of an anesthetic, et cetera, they tend to go with radiation. But there's no absolute sort of indication. There's no rule that says this age needs this and that age needs that. Within my cohort, so amongst urologists, it's fairly uncommon to operate on a patient above the age of 76, 77. 80-year-old in excellent health, again, maybe, but we don't love it. Patients under 70 would tend to have radiotherapy. And then there's that group between 70 and sort of 75 where it cuts both ways. And that tends to be how it goes. One of the things to remember, particularly in younger patients, if we are worried that it's high-grade disease and that we may need to consider multimodal therapy, then in that scenario, surgery is better to do first. It's a lot easier to give radiotherapy after surgery than the other way around. And the main reason being because after radiotherapy, the tissues around the prostate, the rectum, the bladder are changed. And so going in there and operating is more difficult. And so we end up, the risks of all those complications are tenfold higher. So rectal injury can be up to 10%. Incontinence is like 30%. So that's sort of the deal in relation to treatment. Take-home message: prostate cancer is complicated, and the main reason being it's more related to the natural history. It's common, it increases with age, and it has a long natural history. Not all patients need to be diagnosed or actively treated. All patients should have an open discussion about all treatment options. And I guess I always say to my patients, you know, they sort of look to me, oh, you know, what should I have? You know, in some scenarios, I really don't have the solution for them. They could literally have surgery. They could absolutely have radiation. And I think really I always say to the patients, look, this is a decision that you actually don't really want to make, but you're going to have to. And at the end of the day, you need to think about what fits best for you. We'll always have decision regret if the situation doesn't go the way we want it. Fortunately, usually it does. And in that scenario, you know, if the decision doesn't go the way you want it, it doesn't matter what you decided to do. I mean, if both ways, you're going to regret you didn't do the other way. But, you know, fortunately, complications or significant complications are uncommon. I think that's everything.
Thanks, Adee. I do have, this is the chance, everyone. If you've got any questions, please pop them in the question and answer box. There is a couple that have come in. How many times / how often should low risk men be tested in the age 50 to 69?
So is that after we've had a diagnosis of a cancer, or are we just screening with a PSA?
Well, I don't know.
So I would say yearly. So in answer to where you've got your patient who has bloods and the PSA is normal, then a PSA every 12 months, 12 to 18 months, effectively make it part of the, again, depending on whether the patient has bloods all the time, but really they don't need it more than every 12 months.
Okay, thank you. The RACGP's Should I Have Prostate Cancer screening tool makes a point of 1 in 1,000 lives saved and a significant number having some potential harm from testing. Any update on local data on those saved or receiving significant benefit?
I must admit, I couldn't tell you specifically. We have the prostate cancer registry has that information, and I must admit I haven't. We the Urological Society don't necessarily agree with the GP Society's take on all of this. I think the key here is not necessarily that. The key is, and I guess that's the responsibility of the urologist to ensure that they're not being overzealous and over-treating. But the data is going to change as we have adapted our practice. And I can tell you in my own practice and just amongst our teaching colleague, we are treating less patients aggressively. So I think the harm, that sort of harm or the over-treatment arm is going to decrease, but it will take time. I can't quote the number though. But the point is that we got into a situation, or we were heading into a situation where we were throwing out any form of PSA testing at all. I can speak from the American experience that in 2012, they're called something different, like the family practice, or they've got a family physician, but it's the equivalent of the GP. They essentially had a recommendation, level D, where they basically said PSA testing does more harm than good. And that was put out in 2012. And I think when they re-looked at the data about 7 years later, the prostate cancer outcomes were worse. So they've actually revised that. And so I think, again, PSA is not a wholesale screening tool. That's not the intention. And kind of we don't want it to be used in that way. It's really just to try and flag patients on a whole, taking the whole picture in, who may be at risk of having prostate cancer, who may then benefit from treatment. But it's a more nuanced assessment. Does that sort of answer the question?
Yes, thank you very much. Could I just take this on? There's no other questions. So could I take this opportunity to thank you so much, Adee and Bridget, for conducting our prostate cancer update this evening. And I will end this webinar for everyone. Thank you again. And don't forget to fill in the survey. Good night.